total bilirubin. And they use the cutoff 5-fold above. It looks like a hepatocellular pattern. And then if it's more between 2 and 5, maybe cholestatic pattern. And if combined with the ELP, and the ratio of ELT-ELP more under 2, we can predict maybe it cholestatic pattern. And chronic delay, like what I told you before, it can persistent until 1 year, more than 1 year. And then this is some classification of severity of DILI. They use ELT and usually total bilirubin in this U.S. drug-induced liver injury network. They actually they use the total bilirubin more than 2.5 milligram per deciliter. And International DILI Expert Working Group, they also make the cutoff of ELT that more than 5. In 2019, EASL make like an indicator to predict the DILI. They call it high-low cases, because they use this because this is more sensitive and specific as the predictor of drug potential to cause severe hepatotoxic. And by using this indicator, they try to reduce the fatal condition that need liver transplantation, at least 10% of cases. And the point of the highest low is, the first is, if the incidence of increase of the ELT is 3-fold or greater of ELT or ESG, or individual showing ELT more than 3 combined with total bilirubin 2, even though there are no initial finding of cholestasis, but there's the elevated of ELP. And the third is, there are no other cause of liver disease that we have already confirmed that there are no condition that can make it icteric or increase of transamination enzyme like hepatitis B of acute liver disease. And this matching criteria 2 and 3 that refer highest low cases, 2 from these 3. This is the comparison between the intrinsic and idiosyncratic DILI. We can see here there are some drugs that already have the recommended dose. There are the cutoff of the dose that can make the DILI event. This is the presentation of DILI in autoimmune hepatitis. We can see it can have the many variety of manifestation, from the rash, fibrosis, and then respond to steroids or no. Okay, and this is also the pattern that we already know, that the pattern of the using anti-tuberculosis, the pattern of injury usually hepatocellular, and then for amoxicillin, usually cholestatic injury. And it's already taught before that the etiology of non-acetaminophen cirrhosis and elderly aged more than 60, it can have the significant impact on long-term survival. And the pathophysiology of DILI, we can see here that from the drug and metabolic, the intrinsic toxicity usually have the direct impact to the cells that can make the oxidative stress, and then injury in organelle, mitochondria, and so on intracell, and then make the cell become necrotic and apoptosis. But the pathway of idiosyncratic, beside there's the genetic condition that can make it easier for the person to have the DILI, there is some other immune-mediated mechanism that can make the person prone to have the DILI. Now let's see the condition, the comorbidity of the chronic liver disease, for example, hepatitis B or C in dairy. There is the systematic review in 2015 in China. They show that if the person use the anti-tuberculosis in the person with hepatitis B, some show that the daily risks become increasing. We can see here with the TB for combination drugs, or even only one drug can also make the increasing of ELT. Some of them show the ELT. It show that daily in anti-tuberculosis prone to be hepatocellular injury. And we can see here also the odds ratio. In some research show that in patient with HBV, it prone to have DILI when they use anti-tuberculosis. And actually, HBV and DILI, there are so many research already show the correlation between this condition that can make the DILI become prevalent. Patel and Foyk first demonstrated that only the positive HBV carriers have the higher risk of anti-tuberculosis DILI. And the other research by Wang also showed that only HBV carrier with high viral load HBV DNA have an increased susceptibility to anti-tuberculosis DILI. Therefore, that it show maybe there is the activity of HBV that may play an important role in the development of anti-tuberculosis DILI. But however, the data that show really the direct correlation between HBeAg and HBV DNA are lacking in most of relevant studies. So this is still like make the correlation, but we cannot, until now we cannot say that there is causal effect of the HBV hepatitis B virus directly to the mechanism of the DILI. Maybe the reason why HBV carriers have high risk of AT-DILI remains to be elucidated. However, several explanations have been proposed, including a suspicion about reactivation of HBV with flare-up hepatitis, and which has manifested with high HBV DNA and positive HBeAg in some patients. So they say that maybe because of the HBV and then the condition of high virus and then the flare make the condition of the liver become hepatitis. So this prone to have the more inflammation when they have the drugs that can cause the DILI. And now we talk about the meta-analysis suggests that chronic hepatitis C infection also may increase the risk of anti-tuberculosis DILI. Why in some papers show the anti-tuberculosis DILI? Because this is the idiosyncratic that we know that idiosyncratics in some DILI condition rather difficult to predict and not dose dependent. And because the anti-tuberculosis drugs are the drugs that many people use in the world, especially in Indonesia. And here also the systemic review and meta-analysis also same like hepatitis B. They show that the main criteria using ELT and with the drugs anti-TB for combination or only isoniazid only. And we can see also the deterioration of liver function due anti-TB induced hepatotoxicity. If the patient have the chronic liver disease or even cirrhotic, the recovery of the DILI becomes slower and then difficult. And it showed that they also have the prone to have the liver failure and also the death. And this is, we can see that there is the paper in 2014 by Kumar, and they said that for the cirrhotic patient, they proposed about Child-Pugh A, B, C. For the Child-Pugh A, if we want to use anti-tuberculosis, we still can use two hepatotoxic drugs, for example, isoniazid and rifampicin, but without pyrazinamide. With maybe a low dose and duration 6 until 9 months. But if the patient have the Child-Pugh B, ideally only one hepatotoxic drugs can be used without pyrazinamide. So it shows that pyrazinamide actually proposed not to be used in cirrhosis patient. And for Child-Pugh C, no hepatotoxic drugs to be used. We can use another second-line anti-tuberculosis drugs. And this is the study on hepatotoxic anti-tuberculosis drugs in combination therapy. And there are some, looks like the risk factor are female sex, advanced age, alcoholism, and so on. This is the algorithm if we use the drugs. First, of course, we have to have the baseline ESD-ALT, and we have to carefully determine whether the patient already have the chronic liver disease previously before they use the anti-tuberculosis disease. And then we have to monitor it, we have to monitor the liver function test, and we see the ELT, ESD, bilirubin, condition to the drugs, and if the drugs, if DILI happen, we have to stop first the drugs, and then until the condition become, the bilirubin become under 2, ELT become under 2, we can start again the drugs if we still need it. For example, here, isoniazid from the lower dose first. And we must follow up the increase of ELT, EST. And there's a systematic review about the use of acetaminophen in 2018. It said that actually in the systematic review show, actually there's the specific recommendation of limiting acetaminophen dose less than 2 to 3 grams per day is not supported by high quality trial, particularly when acetaminophen is used chronically. There is insufficient evidence to recommend that we have to reduce the doses or avoid the use of acetaminophen in cirrhosis patients. So it seems need more research to confirm that the dose acetaminophen more than 3 grams must be prevented. And then this is idiosyncratic short review about DILI. And there's the guideline how to treat the DILI. We can see here first how we have to confirm whether the patient have the prone to have DILI or no, like I already described before. So elevation of ELT is preferable over EST to diagnose the DILI. And then actually serum ELT can be over 100 upper limit of normal ELT in some patients with DILI. However, but actually DILI can present without significant elevated ELT level. So if we see the ELT level increase not more than 100, it doesn't mean that we say that, oh, this is no DILI. Actually, we have to be careful to diagnose the DILI. And we have to exclude some other etiology of the DILI. Actually, this is the method, other method that can make it easier to defer the hepatocellular condition or cholestatic DILI. Why this score can be used? Because this score have the user-friendly and cost-saving method, but for this score, is not designed if we still suspect chronic DILI. So this score can be used if we already known that the person have the chronic liver disease previously. But in some conditions, sometimes we cannot differ whether this is DILI or the acute condition in chronic liver disease. We need the expert hepatologist opinion. And the treatment, here we can see that for the idiosyncratic, we can give the NAC, acetylcysteine, and then sometimes the routine or corticosteroid can be used, but this is not as the regular using. And then actually no definitive therapies are available for idiosyncratic DILI with or without ELF. However, NAC may be considered in early stage ELF, acute liver failure. And then the strong condition is to stop the cause of the DILI. This is how to make the grading of the condition that using immune modulator drugs. So the summary that we in acute viral hepatitis should be excluded from the first time when we have the condition, whether this is DILI or no. And then in individual with suspected cholestatic DILI, sometimes we need the abdominal imaging, ultrasound to make the differential diagnosis with obstructive icterus. And then actually the diagnosis of the inpatient CLD, and then the treatment should be carefully. Okay, and then we have to stop the drugs if the ESG more than 3, stop all essential drugs, and then treat the condition. And actually liver biopsy not always need to be performed in some patient. We can perform if we cannot differ whether this is the acute condition in chronic liver disease or no. And the prognosis, actually the prognosis
Excuse me.
Okay. And the conclusion, we need to assessing the chronic liver disease as a risk factor of DILI, and then it can be a risk factor that DILI cannot recover well and become the chronic DILI, and special care is needed for antiviral therapy in chronic hepatitis B and C. Thank you very much.
Thank you, Dr. Cynthia. Interesting presentations. Next speaker will be Dr. Andri Sanityoso. Please welcome. Dr. Andri Sanityoso is from Cipta Mangunkusumo Children's Hospital, education intermediate specialist from University of Indonesia, and consultant cardiology hepatology also from University of Indonesia. In 2015, he graduated as doctoral program medicine faculty University of Indonesia. Please present.
Thank you, Mr. Chairman. Good morning, dear colleague. So I will present regarding the precaution and the assessment for DILI, prevention from tuberculosis drugs. So I really sorry if there is any overlapping slide with the previous speaker. This is the outline of my topic. There's some slide for introduction. So we know that tuberculosis remain a major global health problem despite the availability of highly efficacious treatment for decades. And we know that DILI, secondary to anti-TB treatment, is reported in 2 until 28% of patients, varying with the definition or study population and treatment regimen. And hepatotoxicity is the commonest of all adverse effects leading to the drug discontinuation in 11% of patients treated with combination of isoniazid, rifampicin, and pyrazinamide. So, DILI due to anti-TB drugs. DILI may occur with all currently recommended regimen for the treatment of latent TB infection, including isoniazid for 6 to preferably 9 months, rifampicin for 4 months, or isoniazid and rifampin for 4 months. In this slide, we can see there is factors of TB DILI. So it's divided, the risk factor divided into the regimen of drugs, including the treatment regimen, drug dosage, and also the pharmacokinetic of the drugs. And in regard of the patient factors, including age, gender, nutritional status, and also alcohol consumption, also if there is co-infection, and genetic susceptibility. So we discussed regarding the drug factor, the treatment regimen. There is hepatotoxic like isoniazid, rifampicin, and pyrazinamide. Or maybe hepatotoxic like a fluoroquinolone, or not hepatotoxic, for example, ethambutol and streptomycin. The previous speaker also mentioned regarding the intrinsic DILI and idiosyncratic DILI. So in intrinsic DILI, related to the dose and occurs in a large proportion of the population, expressed to the drug and predictable, and symptoms begin from a few hours and to several days. In idiosyncratic DILI, not related to the dose and not related to the dose, although there is a dose threshold 50 to 100 milligram per day, and the onset of symptom from a few days to week is referred to as variable latency. This is the biochemical pattern of liver damage and related drugs. So there are hepatocellular type, cholestatic pattern, and mixed pattern. We can see here that the TB drugs belong to the hepatocellular pattern, like isoniazid, pyrazinamide, and also rifampicin. The biochemical pattern of DILI, we know there are 3 patterns of DILI determined using earliest identified elevation of liver enzyme level. Initially, ELT activity, so patient ELT per upper limit of normal of ELT, and ELP, patient ELP per upper limit of normal of ELP is calculated, then ratio between ALT and ALP we know as R ratio. So if the pattern is hepatocellular, if ALT alone is elevated more than 5-fold above upper limit normal, or R ratio more than 5. And the cholestatic pattern, we can see that ELP alone is elevated 2 or more fold above upper limit normal, or the R ratio is less than 2. Also the mixed pattern, the R ratio is between more than 2 and less than 5 times for the mixed pattern. So this is the mechanical relationship between intrinsic and idiosyncratic DILI. We know the relationship between these two types need a common prerequisite for intrinsic toxicity and idiosyncratic DILI is the metabolism of lipophilic drug in the liver, generating reactive metabolite which lead to the initial consequences such as covalent binding, the covalent binding, oxidative stress, signaling, and organelle stress response. The specific pattern of hepatic damage, there are several sites we can look here. That first, the disruption of intracellular calcium hemostasis, cell membrane will make cell membrane bleb formation, rupture, and cell lysis. The second, the cholestatic damage, disruption of the actin filament adjacent to the canaliculus. The next is interruption of transport pump and loss of villus processes. Then reaction involving cytochrome P450 system and the activation of apoptotic pathway and program cell death, and also inhibition of mitochondrial function. Let's start with isoniazid. Isoniazid is the TB drug that most often causes hepatotoxicity, and with the monotherapy, the hepatotoxicity from 0.1 to 0.56%. Odds ratio hepatotoxicity in the treatment of isoniazid is 1.6. But when added to rifampicin, the odds ratio increased to 2.6. And risk factors for isoniazid hepatotoxicity is slow acetylators. Slow acetylators is phenotype of the slow acylated NAT2 gene. So if slow acylator will increase risk of hepatotoxicity 4 times. So this is the mechanism of hepatotoxicity of isoniazid. See the isoniazid is metabolized and cleared predominantly in the liver. The key enzyme in the metabolic pathway is NAT2. And microsomal enzyme cytochrome CYP2E1. It will determine the risk of hepatotoxicity. And NAT2 is responsible for metabolism of isoniazid to acetyl isoniazid, which in turn is hydrolyzed to acetylhydrazine. Later could be oxidized by CYP2E1 to form an hydroxyacetylhydrazine, which further dehydrate to yield acetyldiazine, and this is have the hepatotoxide metabolite. How about the rifampicin? Rifampicin, is the drug metabolite rifampicin, is not toxic to hepatocyte. So rifampicin is associated with hepatocellular type DILI. Rifampicin can increase hepatotoxicity of other oral anti-TB, so have potentiation effect, and rifampicin interferes with bilirubin uptake and bilirubin excretion because it inhibits bile cell exporter pump, causing indirect hyperbilirubinemia without hepatocyte damage. So this is the potentiation effect of rifampicin. The combination with rifampicin will potentiate the hepatotoxicity effect. Rifampicin will increase the metabolic pathway of CYP2E1, resulting in an increase in isoniazid metabolism, which produce toxic metabolite. Rifampicin also increases the activity of the isoniazid hydrolase enzyme, which increase the production of toxic hydrazine, especially in slow acetylators. And pyrazinamide, the half-life of pyrazinamide is longer than isoniazid and rifampicin. It is longer in patients with impaired liver function and in patients taking xanthine oxidase inhibitors such as allopurinol. And pyrazinamide toxicity depends on the dose given drug, so it is dose dependent. And pyrazinamide inhibits the activity of cytochrome enzyme that interfere with the metabolism and excretion of the drug. So how about how to assessment the patient with the DILI due to the oral anti-TB? So the diagnosis of DILI is a diagnosis of exclusion. The clinical history, time of drug exposure, and course of liver damage are crucial. And the clinical presentation of DILI range from asymptomatic to acute and chronic hepatitis. Approximately 20 to 30 patients who develop DILI display symptomatic of an allergic drug reaction such as fever, rash, and eosinophilia. And acute liver injury is often detected and confirmed by liver biochemical blood tests. So this is the stepwise approach to DILI diagnosis. So if we found the abnormal of the liver enzyme and we suspected of DILI, so we have to looking for the features that supporting the toxic etiology, for example, like skin involvement, kidney injury, and the previous DILI episode. And we then have to careful inquiry of the exposure to herbal or dietary supplement, drug, OTC. Then we have to careful the potential pitfall like lack of information, for example, dose or duration, and combination several medication or hidden on the counter and herbal and dietary supplement. So if we then we have to calculate it, the R ratio. So if the R ratio is more than 5, so this is the pattern of hepatocellular, and between 2 and 5 is it mixed, and the R ratio less than 2 is it cholestatic type. So then we can search for another possible cause like we have to exclude the viral infection, alcoholic, ischemic, autoimmune. Then we consider liver biopsy if negative or incomplete the challenge. So still we have to think of liver biopsy. This is the method that we can assess to help assessment. So previous speaker already talking about the RUCAM score, and there are still another score like Maria and Victorino score. They analyze the parameter of several aspects, and then the result have 5 probability level, like high probable, probable, possible, not likely, or excluded. This is the other scale like Naronjo scale and Dillon. So there are, we can use this scale, the score, for helping the assess the causality. The famous one is the RUCAM score. We can see this is the RUCAM score, and the parameter to assess the RUCAM score, like a time to onset of ALT or decrease ALT after stopping drug. We can see here the score, and we then looking the scoring system. So the highly probable if score more than 8. The EASL also recommendation for laboratorium and ultrasonography. The recommendation is the test for HCV RNA and anti-HIV IgM suggested in patient with suspected DILI to exclude acute hepatitis C or E. Also, they recommend to an abdominal ultrasound should be undertaken in all patients suspected of DILI, and the use of additional imaging study relies on the clinical context. Now we move to the treatment. So this is the algorithm that we can use for the evaluation pre-treatment. We have to looking for the identity, the TB risk, if there is any hepatitis and pre-existing liver disease, and we can proceed if the patient pregnant. If no, we can proceed to the treatment. But if patient pregnant, we can assess the TB risk. If low risk, we can defer the TB treatment. But if high risk, we can proceed to the treatment. And also, if there is a TB risk, so we can check for the ALT, bilirubin, and INR. And if we no TB normal, so can proceed to the treatment. This algorithm is the monitoring. If we already start the treatment, and we can monitor guided with this guideline. This guideline also we can see if there is the risk factors, so we have to be careful. If there is sign of symptom, we have to be stop the treatment.
Time is up.
Yes, so I will proceed to the prevention. So this is the prevention. If patient at risk of hepatotoxicity, we have to be careful. We have to adjust the drug with only two hepatotoxic or one hepatotoxic or no hepatotoxic drug. And also we have to educate patient who will get the TB drugs. The patient have to recognize symptom of drug hepatotoxicity if there is immediate seeking medical help. do not continue alcohol and do not consume drug. So, ladies and gentlemen, the conclusion is TB remain a major global health problem despite the availability of highly efficacious treatment for decades. And DILI is a relatively rare event, but it can have serious consequences in some cases. Isoniazid is the TB drug that most often causes hepatotoxicity. And the re-challenge is considered when it is unclear which medication was the cause of the symptoms or of transaminase increase. Thank you for your attention.
Thank you, Dr. Andi Santoso, for your nice presentation. Next speaker will be Dr. Martin Romendi. He is internist and consultant in pulmonology, and also graduate as doctor program in Medical Faculty, University of Indonesia. Please, time is yours. Dr. Martin Romendi will present respiratory failure and liver cirrhosis.
Okay, good morning, everybody. First of all, I want to thank for the to the committee that give me opportunity to be speaker in this session. My topic is about respiratory failure in liver cirrhosis. As we know, lung is the most important organ that could be affected by patient with liver cirrhosis. And there are many kinds of lung abnormality that may be related to the depression of immune system, and also related by the advance of the liver function. It's about 8% patients with liver cirrhosis will develop acute respiratory distress syndrome in patients admitted in ICU. There are many modifying factors that contribute to developing of the acute respiratory distress syndrome, such as alcohol consume, and also patient with many organ dysfunction with multiple comorbidity. This is also a risk factor for developing of acute respiratory distress syndrome. Patients with chronic liver disease and even with liver cirrhosis may develop hypoxemia that related to the many kind of abnormality of the lung, such as pneumonia that most likely due to the translocation of the bacteria from the gut into the vascular of the lung, and also caused by the accumulation of the fluid in the pleural cavity due to the developing of hepatic pulmonary syndrome, and also by the hydrothorax. This is the most of the complication of the lung in patients with liver cirrhosis. So in liver cirrhosis patient, the immune dysfunction may lead increase to susceptibility of the sepsis and pneumonia. Besides pneumonia, there are many predisposing factors that could be cause the lung edema, such as patient with accepting multiple transfusion may develop transfusion-related lung injury. And also, patient with accumulation of the fluid caused by the hepatitis hydrothorax, the lung may develop atelectasis, and also in confusion states in patient with hepatic encephalopathy, aspiration may also develop that may cause patient with pneumonia with acid and reflux of the food. There are some of the lung abnormality related to the ancestral risk factor. Aspiration may caused by altered developmental of the patient with hepatic encephalopathy. Pneumonia also caused by bacterial translocation from the gut. And volume overload may also develop caused by blood product transfusion. And trali also may develop caused by immune mediation system. And the most frequent complication of the lung in liver cirrhosis is, from my experience, is pleural effusion caused by hepatic hydrothorax that may cause the atelectasis of the lung. And also, ERDS is the most fatality cause of patient with liver cirrhosis complicated with the lung. This is the data from research that compare patient with acute respiratory infection in liver cirrhosis and acute liver cirrhosis without acute respiratory infection. In this diagram, we show that there is a significant difference between both of the patients. Patient with acute respiratory infection has higher mortality rate in rate of the patient in 1 year following. For the ARDS itself, it may develop caused by the sepsis, pneumonia, aspiration, and multiple transfusion, and also pancreatitis. If we look at the ERDS definition, this is the syndrome that, by definition, developing within 1 week of non-clinical insult of worsening of the pre-existing of lung abnormality. And in RDS, from the chest imaging, may reveal a bilateral opacity that not related with effusion or atelectasis or nodule. And the lung edema itself is not related to the cardiac failure and also with cardiac overload. As a clinician, especially for the pulmonologist, to make sure about the ERDS itself, we have to exclude the possibility of another cause of lung edema. So we have to perform some examination like echocardiography to evaluate whether the lung heart function is normal or already reduced. For ARDS itself can be graded into 3 stages: mild, moderate, and severe. Okay. With we look at the partial pressure of E2 and fraction inspiration of E2. If you look at the liver cirrhosis itself, there are specific lung abnormality related to the advanced liver disease. There are hepatic pulmonary syndrome, portopulmonary syndrome, and hepatic hydrothorax. Hepatopulmonary syndrome caused by vasodilatation of microvascular vessel in the lung, caused by the presence of the many substance that cannot be destroyed by the lung. In the upper side, the portopulmonary hypertension is the result of increasing of the arterial vasoconstriction in the lung due to prolonged hypertension related to the pulmonary artery hypertension. And the hepatic hydrothorax, this is the most frequent abnormality of the lung for me as a pulmonologist that we find in patients with end stage of liver disease. If you look at this data about the involvement of the lung in end stage renal disease, we see that actually hepatopulmonary syndrome, this is the most frequent of the lung abnormality. But from my experience, many patients with liver cirrhosis in end stage, hepatic hydrothorax is the most frequent of lung abnormality. And for the management of the lung acute respiratory failure in liver cirrhosis, principally we have to manage the patient as we can, patient not to be intubated, because once patient get the intubation, the mortality rate will be higher compared with patient with spontaneous breathing. So in this case, we have to correct the cause of the lung abnormalities, such as if there is infection, we have to give the strong antibiotic according to the severity of infection. And if there is fluid of the lung, accumulation lung cavity, we have to remove as much as we can. And from this procedure, we hope we can postpone at least patient to be intubated. We can use the non-invasive ventilation with high flow nasal cannula. In this measurement, the patient still have spontaneous breathing, and we give the high concentration oxygen through the canal nasal. And hopefully, with this measurement, the patient will get the enough oxygenation, and we can prevent patient to be intubated. Sometimes the patient condition becomes worsening, and we have to do the intubation, and we perform the intubation of the patient, and meanwhile we treat the cause of the lung abnormality. Principally, if the patient already improving after giving the antibiotic and take out the fluid in the pleural cavity, we have to try to win patient for the ventilator, because the long-term use of ventilator will related with higher mortality of the patient. So this is the principal management of patient with lung involvement in end-stage liver cirrhosis. In summary, in patient with end-stage renal disease, there are many kinds of lung abnormality. The most important abnormality in my experience is hepatic hydrothorax. After that, the pneumonia, and after that, the atelectasis due to compression of the fluid. Many patients with hepatic hydrothorax need to be inserted by the pleural drain, and sometimes we have to take the indwelling pleural catheter to continuously remove the fluid from the pleural cavity. Or if the patient is want to be function serially, we can perform the pleural function serial according to the increasing of the pleural fluid. Hopefully, with appropriate management, we can treat patient with liver disease to get the complication of the lung, especially infection, and also pleural effusion by giving the fluid and measure the balancing of the fluid per patient. And also, we give the education for the patient to avoid the exposure with noxious substance and also avoidance of infection. I think this is my presentation with this topic. Thank you for your attention.
Thank you very much, Dr. Mutrimini, for your nice presentation. The last speaker will be Professor Rino Agani from Indonesia with the title Fungal Infection Management in Liver Cirrhosis. He's now the head of Hepatobiliary Division at the Department of Medicine, Faculty of Medicine, University of Indonesia, and is also a consultant of gastroenterology and also a doctor in medicine, University of Indonesia in 2011 until now. So please, the time is yours, Prof. Ghani.
Thank you, moderator. Good morning, ladies and gentlemen, dear colleague. My task this morning is to bring you the presentation with the title Fungal Infections Management in Liver Cirrhosis. Excuse me. So, dear colleagues, we know patients with liver cirrhosis, especially decompensated liver cirrhosis, have a kind of some immunocompromise. So, infections is the main problem in patients with decompensated liver disease, such as patients in liver cirrhosis. This is my outline of the presentations. The first is the epidemiology of fungal infections in liver cirrhosis, and the second one is the characteristic of patients with spontaneous fungal peritonitis, and then the presence of relevant comorbidities, spontaneous peritonitis due to fungi and fungicides reported, and diagnosis of spontaneous fungal peritonitis. And then we will close with the management and prognosis and mortality of fungal infections in liver cirrhosis. This is the survey by the leading international fungal educations portal who facilitated the estimations of the burden of serious fungal infections by country of over 5.7 billion people, or more than 80% of the world's populations. And they found out that the most prevalent of the fungal infection is Candida species, especially Candida albicans and Candida glabrata. And this is also reported by most of the Asian Pacific countries, including Indonesia. So the spontaneous fungal peritonitis can have a severe complications in patients with advanced liver cirrhosis. And this can happen because of nosocomial peritonitis, and in patients with a Child-Pugh score more than 7, the prognosis can be quite bad. So in liver cirrhosis, fungal infections is an emerging problem in cirrhotic patients and usually fatal. Candida species infections account for more than 10% of total invasive fungal infections, and cirrhotic patients with candidemia more than 50%. Intra-abdominal candidiasis, which includes also commonly reported. In these patients, higher mortality rates were associated with Candida tropicalis candidemia compared to Candida other than Candida albicans, such as the Candida parapsilosis or glabrata. In spontaneous peritonitis due to fungi, antibiotic treatment of spontaneous bacterial peritonitis may increase the risk of fungal peritonitis by allowing excessive fungal growth in the intestinal flora. So, although the molecule of fungi is quite big, but fungal translocations may be facilitated by upper gastrointestinal bleeding or by history of paracentesis. This is the study, several studies that shows Candida is the main pathogen in patients with liver disease and also in liver dysfunction, especially the Candida albicans, but also non-Candida albicans. So the predictors of development of fungal infections in cirrhotic patients, you can see that this is the study in 1,691 cirrhotic patients with bacterial infections and 134 fungal infections. Male gender may be shown to be protective factors with reasons unknown, but the main predictors for development of fungal infections was diabetes, acute kidney injury, ICU admissions, and also admissions with bacterial infections, which is in liver cirrhosis. In patients with liver cirrhosis, sometimes the use of long-term antibiotics. Spontaneous peritonitis by fungi in management algorithm. If we suspected patients with peritonitis due to fungi, immediately perform ascites or blood culture. In high-risk patients for spontaneous fungi peritonitis or invasive fungi infections, start antibiotic and antifungal therapy. And then, if the patient is low risk, maybe we can start antibiotic alone. If the pathogen can be isolated, but the de-escalation therapy can be done. If no pathogen can be isolated, we should continue the therapy. In low-risk patients with spontaneous fungi peritonitis, after the pathogen can be isolated, the therapy can be tailored due to the pathogen that isolated. If no pathogen isolated, if clinical improvement happen, the therapy should be continued. But if no clinical improvement, we should add on antifungal therapy. So this algorithm essentially showed that the antifungal therapy should be start earlier because of the mortality of the patients with fungal infections can be high in patients with liver dysfunction or liver cirrhosis. For the antifungi that can be used, the most important one is we know that the azole derivatives such as fluconazole, ketoconazole, itraconazole can be used in patients with Candida albicans. But in patients with liver cirrhosis, the adverse effect of the azole therapy that may worsen the liver conditions should be considered. Other than that, the amphotericin B can also be used, but this also have many adverse effects. So the other groups is the echinocandins. Echinocandins essentially consists of caspofungin, anidulafungin, and micafungin that inhibits the synthesis of beta-glucans. And so these echinocandins destroy the wall of the fungi. So it's called the penicillin of antifungals. Echinocandins are recommended as the first-line treatment for patients with liver cirrhosis and nosocomial spontaneous fungal peritonitis, and also in critical patients with liver cirrhosis and community-acquired spontaneous fungal peritonitis. And but the fluconazole is recommended for less severe infections. This is the comparisons between three echinocandins, caspofungins, micafungins, and anidulafungins. And you can see that the anidulafungin is not metabolized in liver, and liver functions such as the MELD score and albumin levels do not affect pharmacokinetics of anidulafungins in critical ill patients. The study in patients with the liver dysfunction and multi-organ failure. The mean durations of treatment, 15 days, and all receive 200 milligrams on day first, and then 100 milligrams from day 2 onwards. And it shows that at the start of the treatment, in anidulafungin treatment, 98% of patients had at least one abnormal liver function test. Yes, because this is the patients with liver dysfunctions already. But during the treatment, 96% of patients still have at least one abnormal liver function test. So this study showed that no increase of liver dysfunctions in patients with already have liver dysfunctions. So factor associated with 20 days mortality, we can use the Apache score, Apache 2 score, or MELD score for the predictions of the mortality in patients with invasive fungal infections with liver cirrhosis. Maybe Apache-2 score may be better compared to MELD score in these patients. Apache-2 score also can be used with also the SOFA score. SOFA score may be better than Apache-2 score for the patients, for the predictions of the mortality in patients with fungal infections. So, overall mortality is still high. In the prognosis of evaluations of patients with fungal peritonitis, we can see that all spontaneous fungal peritonitis, the mortality is 62.5% for overall mortality. And after the treatment success, the spontaneous peritonitis can recur. This is also the problem in patients with liver cirrhosis, and the recurrence is quite high in patients with fungal infections. So, dear colleague, ladies and gentlemen, my conclusions: fungal infections in liver cirrhosis patients can have a high mortality. Spontaneous fungal peritonitis is not very rare, so this must be considered in patients with liver cirrhosis, especially in patients with high risk of fungal infections. So we can start the antifungal therapy earlier. Fungal ascites has a higher mortality rate than the bacterial infections only. Echinocandins are recommended as the first-line treatment for patients with liver cirrhosis and nosocomial spontaneous fungal peritonitis, or in patients with critically ill with liver cirrhosis and community-acquired spontaneous fungal peritonitis, while fluconazole may be recommended for less severe fungal infections. For that, I thank you very much.
Thank you, Prof. Rino. Now I invite all speakers to come forward to sit beside me, because we will start the discussion. Okay, any question, please? Okay, Dr. Stopo.
Thank you. My question is to Dr. Cynthia. Thank you for your excellent lecture, where some people, some researchers stated that no specific treatment for DILI except supportive treatment. My question is, what kind of supportive treatment you recommend in addition to stop the etiologic drugs? What about giving certain hepatoprotector, albumin, vitamin A, or antioxidant? Thank you.
Thank you very much, Prof. Actually, like in my presentation, that first we have to see what cause and what type of the daily of this patient. Sometimes from the drugs that we have already selected, whether this is idiosyncratic or maybe dose dependent. Actually, for the dose dependent is maybe easier other than the idiosyncratic, because for idiosyncratic we don't know sometimes we don't know the mechanism, and then what other factor that can be the predilection factor for the patient become the daily. And first, of course, stop the drugs. The drug that can be, that we predict it become the cause of the daily. And then the second, based on the condition of the patient, whether this is usually only the ELT or the hyperbilirubinemia. And the mechanism sometimes it is inflammation. Maybe that's why some experts try to use like hepatoprotector or like some minofagan and so on, vitamin E and antioxidant, that they believe that it can maybe cut the cascade of the inflammation that can be used. But actually, they are all with the level of evidence not 1A. So, but I cannot say that, no, you cannot use it. We still can use it because until now, some mechanism that interfere in inflammation in daily, we can it can be understood. So that's why we can try it to use it. That is all the drug that you have stated, all our the supportive treatment. Of course, other treatment, for example, if they have the fever, you give the acetaminophen, and then maybe you give the hydration and so on. There are all supportive treatment. But for the hepatoprotected, maybe it still can be used. But I cannot say that it is the recommendation level 1A or no. Thank you.
Okay, thank you.
Please.
Yeah, thank you. Yulwan from Jakarta. My first part of the question, I'd like to have comment from Dr. Cynthia, Dr. Andri, and Dr. Martin. Dr. Martin as a pulmonologist. Before we start TB therapy, is it mandatory for us to check serology of hepatitis B, hepatitis C? Because many times we were consulted from pulmonologists, but not internist pulmonologists, from pulmonologists. They didn't have data beforehand about hepatitis B, hepatitis C, and then the daily happens, and then we were consulted, and we checked after the daily happens. So, do we have to check beforehand? And if we find that the patient, the TB patient, has concomitant hepatitis B or hepatitis C infection, do we have to start preemptive therapy simultaneously with the TB therapy? Okay, that's my first part of the question. Second part goes to Professor Rino. On your algorithm of management of spontaneous fungal or bacterial peritonitis, it is stated that we have to determine whether this patient have high risk or low risk of fungal infection. Is there some kind of scoring or criteria that help us to determine which one is which one has high risk or which one has low risk? Thank you.
Who will be first?
Thank you, Dr. Juan. First, my comment about the serology of hepatitis. If we connect to check the serology of hepatitis just because we want to give the drugs, other than chemotherapy, I don't agree. Just if the reason because of that. But actually, as far as I know, in the world outside our country, to check serology of hepatitis B or C, it already become the general medical checkup. I mean, everyone, it's better to know whether they have hepatitis B or C from the first. So we can get the case as soon as possible. We can know the case as soon as possible. But if it connected with the given of the some specific drugs, and we want to prevent DILI, I don't agree if we check them.
I'm talking about TB drugs. TB drugs. Tuberculosis.
Oh, tuberculosis. Oh, okay. For tuberculosis, I think it's better. It's better. And also for especially for HIV and TB patient, usually we check hepatitis. But for the general patient, actually, it's still not be the consensus as far as I know, especially in Indonesia. But in some countries, it is said only recommended. But it's better. But I cannot say that because for the experts' opinion, it become the guideline. Until now, it's still not become the guideline as far as I know. For the healthy general patient, not the HIV patient, but for the immunodeficiency patient, it should be better to check hepatitis B and C. And for preemptive therapy, you mean concomitant when you give the anti-tuberculosis drug and then you give hepatoprotector, you mean like that?
No, antivirals.
Oh, antivirus. Oh,
Yes.
okay. I think for the in some guideline and also in national guideline, we already talk about the antivirus therapy. For hepatitis C, we know that in DAA era, we know that there is the interaction between the rifampicin and some DAA. So we have to delay the hepatitis C therapy after the rifampicin drugs given. But for hepatitis B, it depends on the condition of the patient. This is no, if I'm not wrong, until now we don't say that we have to treat the patient in immune tolerant patient with hepatitis B with antivirus if they have the if they have tuberculosis. I think we don't have to treat as soon as possible. Based on the condition at the first time we want to give the anti-tuberculosis. So that's why the monitoring is the key to prevent, not to preemptive antivirus therapy. This is my comment. Thank you.
Yeah, regarding the question of the TB, DILI, so according to the algorithm that we have mandatory to identify the high risk for TB DILI. So, for example, is viral hepatitis and the previous liver disease, alcohol consumption. So we have to identify the risk. And then if yes, there is a risk of TB DILI, so we have to check the liver function test. So sometimes this is we forget for the test, and then after the symptoms appear, so we confuse. The baseline we don't have the baseline, so we don't know the increasing of the level of the ELT. So it's better we have baseline level of ALT. And if there is normal, we can start the treatment. Regarding the medical treatment,
Yes.
the medical treatment, recently publications show that the benefit using the curcumin, and also silymarin. So they show that the drastically decreasing of the level of ELT. Especially, we have to be careful in from 4 days until 8 weeks. TB drugs, we have to be careful because the development of the DILI mostly 80% in that period. Thank you.
You don't recommend giving antivirals because the virus is there. If we find the virus is there, and it will increase the risk.
Yeah, depend on the, if we use the AA, careful of the interaction.
Okay.
Because we know that some medication, the AA is contraindicated using rifampicin. But I think maybe for the Hep B, there's no problem.
Okay.
Thank you.
Any comments?
Yes. For me, as a pulmonologist, first, of course, we have to evaluate the severity of disease from the lung and the liver itself. For the lung problem, if the infection of the TB is only slight or moderate, we can postpone the anti-TB drug treatment until the liver function is improving. But sometimes we face with patients with severe pulmonary TB infection like biliary TB, or patient with complication of the TB itself, such massive hemoptysis, sometimes with extrapulmonary meningitis, that we cannot stop the anti-TB drug directly. So we should use another group of the anti-TB drug. I mean, it's the second line and third line drug that we give as the most safe drug for patient with DILI. So although this procedure is not confirmed by the guide of the Ministry of Health, but sometimes we as ophthalmologists or internists or hepatologists should adjust and evaluate. Sometimes we have give the second and third line of anti-TB drugs, waiting for the improving the liver function. Okay.
Thank you.
Okay, Prof. Dino.
As far as I know, there is no scoring for to determine high risk or low risk patients with liver cirrhosis for the invasive fungal infections. But as you can see that one of the studies showed that several conditions makes the patients into the high risk for the fungal infections, such as patients with liver cirrhosis with diabetes, with acute kidney injury, with patients in the intensive care unit. This all the risk that makes the patients have a higher chance to have fungal infections. In this kind of patients, the antifungal therapy should be start earlier, not to wait until the cultures, or results, because we may have to wait at least 1 week for the culture results if we want to have a positive fungal infections or not. So it may have the kind of higher risk for the mortality in patients with fungal infections.
Thank you.
Thank you very much for all speakers. I close the session. Please applause to them. Thank you very much.